Patrizio Lancellotti will talk about the secondary mitral regurgitation. Of course, the first step is to exclude primary mitral regurgitation and to assess that there is no apparent abnormalities at the level of the leaflets. Since secondary mitral regurgitation is usually related to left ventricular disease, he will show us how to assess the left ventricle and using the different parameters that should be evaluated. Afterwards, he will show us how to assess the mechanism of mitral regurgitation and finally how to assess the severity of the mitral regurgitation.
Echocardiography is critical to initial evaluation and longitudinal monitoring of patients with valvular heart disease. And just to let you know, mitral regurg is the most common valvular regurgitations. And today I'm going to focus on the patients with secondary mitral regurg. And when we look at these patients, one important thing is clearly to identify if it is a secondary mitral regurg or if it is a primary mitral regurg. So let me show you the parasternal long axis view of these patients, and clearly here the mitral leaflet appears to be structurally normal. There is dilatation of the mitral annulus, there is a dilatation of the left ventricle, and if we move the probe and we take the parasternal short axis view, and after that if we take the long axis view, we can observe the geometry of the mitral valve and the deformation of the mitral valve that is secondary to the changes in the ventricular condition. It is mainly a disease related to the ventricle than a disease related to the mitral valve, and it is easily recognized on echo by the apical displacement of the mitral leaflet coaptation point, as shown here in this example. So if you like to examine the severity of secondary MR, you need to assess the mitral regurg in three different steps. First, you look at the valve, and let me take again the parasternal long axis view, where here you have the morphology of the valve that is completely deformed due to the attraction by the papillary measure that are here displaced and distorted due to the left ventricular dilatation. And again, this kind of mitral regurg relates to two different things. So an increase in tethering force and a decrease in mitral closing force. So if we can measure now the severity of the mitral deformation, we can use the measurement between what is called the mitral leaflet body and the annulus plane, and this is called the systolic tenting area that is clearly associated with the severity of the disease. And the measurement that can be done is this one between the mitral leaflet body, the annular plane, and here you have the 6 centimeters square of the systolic tenting area, just highlighting the severity of the deformation of the mitral valve. And the normal value should be less than 2, and in these patients, if we have more than 2 and 3, this is associated with a high likelihood of recurrent mitral regurg after any kind of valve repair in this patient. So if we want to continue the analysis of all the deformation of the mitral valve and parameters that should be taken into account, and again, just to highlight this, 3 parameters should be taken into account. The severity of the deformation, and here we have the systolic tenting area using the parasternal long axis view, but we can also use the apical view, and here again you have the displacement of the coaptation points toward the apex. You can have different type of tenting area or pattern. And for sure in some patients it's a bit tricky. Most of them have clearly a symmetric pattern and most have asymmetric pattern that relates to 2 different conditions, the local regional remodeling or the global remodeling. But in these patients, we have 2 conditions. We have a severe global left ventricular remodeling that could be quantitated by the left ventricular volumes, and we have here one of the measurements, and we will see this later on, how we can assess all the measurements regarding the ventricle. But also, we can have an idea of the regional remodeling, that is the displacement of the papillary muscle that is displaced laterally and apically, so attracting the mitral leaflet and giving also a pure restriction of the posterior leaflet. So in these patients, we have the restriction of the posterior leaflet, and we have a restriction of the anterior leaflet as well. But the pattern is a bit symmetric, but also a bit asymmetric. It's a mixed pattern that could be seen in these patients with severe enlarged left ventricle. So what we should measure first the diameter here. We measure it in mid-systole, often in this kind of patients, even if we can measure early diastole or late systole, but recommendation just say that we need to measure this in mid-systole. And you have to measure the distance between these lines traced here and the coaptation point. This is the coaptation distance. When it is greater than 1 centimeter square of 1 centimeter, for sure, this is again a sign that there is a severe restriction and displacement of the mitral leaflets toward the apex of the left ventricle, and often it is associated with recurrent mitral regurg after mitral valve repair. Another parameter that could be used to identify the severity of valve deformation is the measurement of what is called the posterolateral angle. But for that measurement, you need the coaptation depth measurement, and you need the measurement here of the distance of the posterior mitral leaflet. And using a certain formula, you can have some degrees. And when the degrees are over 45 degrees, this means that we have a severe restriction of the posterior leaflet. And again, this highlights just the severity of the deformation. So first, valvular deformation. Secondly, the left ventricular remodeling. And for the left ventricular remodeling, we have to take the apical 4-chamber view and apical 2-chamber view to measure all the parameters that you need. So what we need to do, and that this could be done here, you need to measure the volume, and you take the end diastolic volume and you trace the endocardial border. And in these patients, you can trace here. You have to avoid to include the papillary muscle. You have to go till the annulus, and you just click here and you have the volume. So I already made the exercise of calculating the ejection fraction in the patients, and you can see that we have a very enlarged left ventricle with more than 400 milliliters and an ejection fraction of 26%. So these are two parameters associated with a poor prognosis, and these are also parameters just underlying again the fact that we have a severe left ventricular enlargement. So the last step would be to assess the severity of the mitral regurg, because here till now we have just discussed about morphology. And how to do that? The first is to take the parasternal long axis view, and with the parasternal long axis view you have to search for the mitral regurg. For sure, depending on the gain setting, you can modify the severity of the mitral regurg. And just to show you, if I put this like that, I will have a severe mitral regurg. And if I decrease a lot, I will have no mitral regurg, just by moving the gain. So what it is recommended? It is recommended just to set the gain before the appearance of color noise artifact. This is for first. The second thing that you should do is here is to set the color scale at the highest level, for sure. Let me show you now all the steps to quantitate the severity of the mitral regurg. And of course, when you have this image with the box here, you can zoom the image and you have your regurgitation. And you can even zoom a bit more, because what is important when you try to look at the vena contracta, and you know the vena contracta is the narrowest portion of the regurgitant jet, just downstream of the regurgitant orifice, is important to get the three components of the regurgitant orifice. And just to show you what is important is this. You have these three components here, you have the convergence zone, the vena contracta, and the extension into the left atrium of the jet. And you can clearly measure in this view, that is the parasternal long axis view, the vena contracta. And in these patients, we have 6 millimeter. This means that we are in the intermediate phase. So normally a cutoff over 7 is indicative of severe MR. Below 3 is indicative of mild MR. But in between, it's a bit tough. So we should use other parameters to be sure that we have a significant mitral regurgitation in this kind of patients. And what we could do is to use the apical view. And I will show you now the apical view. So with the apical view, we need again the color. And here you have the regurgitation. With the regurgitation that you can get, for sure, you need to zoom. And why you need to do this? Just to maximize the frame rate, as of course. So in these patients, always use a small box, as narrow as possible. And also the imaging depth should be reduced as narrow as possible. So let me just show you this. So what we have to do here, you have the regurgitation, you have the convergence zone, the zone of contraction, that is the vena contracta, the extension in the left ventricle, in the left atrium. But again, here the jet is originating centrally and a bit directed laterally. And if you try to quantitate the severity of mitral regurg just using this, and this is the regurgitant jet area, again, if you change the gain, you have a severe MR. If you decrease, you will have a less severe MR. So always try to set your machine first, highest scale, also gain setting reduce at the maximum to be sure that you can have a beautiful flow, color flow, to assess the severity of the regurgitation. So what we should do next step, so we optimize the color, we have magnify the selected region, and we decrease the zero baseline to get the hemispheric pisa. And if you see here, I'm trying to acquire at least 3 beats, because like that you can freeze the image and you can scroll back or move just to identify the base frame for measurement. And when you have the base frame for measurement, you can make the measurement. And in this situation, here is the pisa that we can obtain. And how we can do this now, you just go to the pisa here and you measure the pisa radius. But first, before doing the measurement, let me show you something very important in these patients, is the change in the color flow during the systole that could clearly impact the assessment of the regurgitation. For that, you need to put the hand mode through the regurgitation zone, and you have this signal. This is the flow convergence zone during the systole, and you can identify if there is any change or if it's constant throughout the systole. And in this kind of patients, it's very clear that you have an early peak, a late peak, and a mid-systolic decrease that is often observed in patients with secondary MR. And this is called a biphasic pattern. And what we do in practice, we just measure here in the mid-systole the pisa radius. And this will be done in this image where we need to measure the pisa. So we will measure the pisa radius from the regurgitant orifice plane to the maximum. So this means the first aliasing, and we have here the pisa. So the next step to get the quantification is to obtain the continuous wave Doppler of the regurgitant jet. And here you have the continuous wave Doppler, and you just need to trace the envelope. And with the tracing of the envelope, you will get the peak velocity as well as the time velocity integral, and you will have here the measurement of the effective regurgitant orifice area that is 30 millimeters square and the regurgitant volume that is very close to the effective regurgitant orifice area, that is 41 milliliter. So what does it mean? It means that we have a cutoff of intermediate severity of regurgitation according to the guidelines and recommendations, and you know the cutoff is 40 millimeters squared to define severe MR and 60 to define a regurgitant volume that is also severe. But in case of secondary MR, due to the disease of the left ventricle, and also I will show you the shape of the flow convergence zone and the regurgitant orifice, it has been shown that a value greater than 20 for the effective regurgitant orifice area is prognostically important, and we should probably consider an effective regurgitant orifice greater than 20 as indicative of severe mitral regurgitation in the context of secondary mitral regurg related to the ventricular disease and the severe remodeling of the left ventricle. So are there adjunctive signs that could be used in these patients to evaluate the severity of mitral regurg? For sure, yes. We should always measure the transmitral flow, and the transmitral flow here you have the E and the A wave. You just measure the velocity, it is 1.2, and again this is more in favor of moderate MR, and it could be a moderate MR in the situation of primary mitral regurg, but in secondary MR the cutoff value are still not well defined. But if you have more than one, it is for sure something associated with a restrictive filling pattern due to a severe mitral regurg that is present. And in some situation you can also trace the contour of the mitral inflow. So this is the TVI, and with the TVI you just need to get the LVOT flow here across, you see, at the level of the LVOT. You measure it and you can just divide the mitral inflow here, 31, by the LVOT flow here, 13, and if the ratio is over 1.4, is in favor of severe MR, and in this situation is really concordant with a severe mitral regurg. So in other words, if I have to conclude, I would say that we have a patient with severe mitral regurg that is secondary due to a significant remodeling of the left ventricle and a significant changes in the mitral valve deformation. Just to illustrate all the effect of the remodeling process on mitral regurgitation, it is of interest to use the 3D echocardiography. Even if it's not the scope of the presentation, this is just to show you exactly the impact of the remodeling process on the mitral valve leaflet. Here perfectly you can see with this image how the displacement of the papillary muscle tether the mitral valve leaflet and impair their effective closure at the level of the mitral annulus. And you can perfectly see this. Let me just show you all the effect. This is the mitral valve, and you have a view from the left ventricle. And here you have the mitral orifice for sure, the mitral valve, the papillary muscle. You can perfectly underline the geometry of the left ventricle and the connection between the papillary muscle and the mitral leaflet. And if you look here, the axis of both papillary muscle are different because they are attracted apically and laterally due to the remodeling process secondary to the disease, and in these patients, again, it's a dilated cardiomyopathy. Now, maybe to illustrate a bit what I said regarding the regurgitant flow across the regurgitant orifice and the geometry of the regurgitant orifice, let me take a 3D images with color flow Doppler. And here you have different views, for sure sections, and you can crop here just to be sure that you are in line at the level of the regurgitant orifice. And if we are exactly located at the level of the regurgitant orifice, there is something very strange is here. This is the regurgitant flow at the level of the regurgitant orifice, and you have the shape. So this means that it's the real vena contracta, and if you measure it, you will have the vena contracta area. So, and if you look at the geometry and the shape, it appears completely elongated, not round at all, as you think that, you assume that the regurgitant orifice is purely circular. So in this situation, measuring with 2D the pisa or even the vena contracta could be a bit misleading. And maybe it explains why we have a discrepancy between the 2D measurement and the 3D measurement for sure, but mainly between the 2D measurement of the severity of secondary MR and the severity of primary mitral regurg. Why? Because in primary MR, often we have a circular orifice, and here you have an elongated. So this is just the conclusion regarding that. So if I have to summarize the case, I would say we have a severely enlarged left ventricle due to idiopathic cardiomyopathy, inducing a significant change in the mitral valve configuration and apparatus changes, leading to mitral regurg that is severe. And when you deal with the treatment in these patients regarding secondary MR, it's important to take into account the clinical data, but also to integrate all these echocardiographic parameters. So those related to the mitral valve deformation, those related to the left ventricular remodeling process, and those related to the severity of mitral regurg. So good luck.
So the key message is that we have first to exclude a primary mitral regurgitation, and secondly that we have to look not only at the valve but also to the left ventricle to assess the mechanism and the severity of mitral regurgitation, taking into account specific cutoff for secondary mitral regurgitation.